Hi, good morning, good afternoon, and good evening. Welcome to the NSF Prepare Data Workshop on Access, Creation, and Maintenance of Data and Computing Resources for Pandemic Research. I'm Li Shong from Emory University. On behalf of the entire Prepare team and the workshop program committee, we're super excited that you can join us and discuss these important issues. To start our program today, our Prepare program manager, Erin, will give a quick overview of the logistics for the workshop. Then we're delighted to have Dr. James Joshi from NSF to give us an opening remark. Following that, Dr. Madhav Marathi, the PI of the Prepare Virtual Organization, will give us a very quick overview of the Prepare Virtual Organization. Then we will kick off the workshop session today. Erin.
All right, so we're really excited to have you with us, testing out this platform for the first time for us. If you have questions today for our speakers, we would love you to ask them in the live stream chat or tag us on Twitter at NSF_prepare. We'll make sure that the speakers get your questions. If you're watching this after the live stream event, you can still interact with our speakers. You can just put your question or your comment in the comment box below the YouTube video, or again, ask us on Twitter, and we'll make sure that your questions get to the presenters. In the future, when you want to watch this later, you can always find it at our Prepare YouTube channel, or you can go to our website, prepare-vo.org. All right, now we would love to have James Joshi, the program director from NSF, join us.
Thank you, Erin. Hello, everyone. Good morning, good afternoon, and good evening again, depending on where you are. Let me also welcome you all to this very, very important event. I would like to take a moment to thank the program committee, the Prepared project team, its steering committee, and all the people involved in creating and organizing this workshop and planning future events. And very special thanks to all the speakers and thanks to all of you attendees. I'd like to provide a very quick background on this initiative that we now call Prepare Virtual Organization. Last year around this time, we at NSF were very busy funding rapid projects, as some of you may know, to address various challenges during this pandemic. And this was besides other NSF initiatives relevant to the pandemic that we were pursuing. And some of these efforts or initiatives were supported through the CARES Act funding that we received. We were starting to discuss internally about how to bring the SAIS researchers working on pandemic-related challenges together. So we were very pleased to receive and fund this proposal from Dr. Madhav Marathi and the team to create this virtual organization with the goal to bring together the SAIS and related multidisciplinary research communities that are focused on solving problems that we were facing, we are still facing during this pandemic. And in order to foster collaboration and coordination among researchers, research teams, to share ideas and to cross-fertilize them, to assess what SAIS community, the Computing and Information Science and Engineering community, has innovated in the past that has been very helpful during the pandemic, and what could have we done better in terms of research and innovation. And personally, most importantly, I think to understand better how SAIS and other collaborators from different communities can better understand and address the challenges so that we are prepared for future pandemics of this scale or even worse. So through the outcomes of the activities organized by this virtual organization, we at NSF are very eagerly looking forward to be informed about what research NSF needs to prioritize, what future initiatives we should think about, and so on, so that we prepare ourselves for facing the challenges in future pandemics. Again, I would like to welcome you all to the workshop, and please share your ideas. Thank you, and back to you, Erin.
So Madhav, we would love to hear from you.
Sure, Erin. Let me also start by saying good morning, good afternoon, and good evening to everyone. I'll keep this short. I know that there's a very exciting line of speakers that we have today and tomorrow, but I want to take a brief moment to first of all thank the program committee and the speakers who have so kindly agreed to give their time to this workshop. Workshop like this do not happen without the intense efforts people in the background, and I want to thank all of you folks for taking the extra effort to make this successful. I also want to thank NSF for supporting this important initiative. We think that this initiative can really galvanize the field by bringing together folks to really address an important societal problem that we currently face. If I could just take 30 seconds and tell you what the mission of Prepare is, so that folks who are attending this today and are likely to listen to this on the YouTube channel later on can choose to join this virtual organization. The Prepare virtual organization has four broad uh, goals. One is to identify and foster new research efforts resulting from the cross-fertilization of ideas in various sub-disciplines within science, but also in time going beyond science, but all the topics in science and engineering. Second, it aims to create a research roadmap that proposes research directions that researchers can lead to and develop effective methods to prepare and recover from future pandemics. Third is to facilitate the collection of comprehensive data sets and tools that can be shared by the community and hopefully can be used to respond in a far more effective manner should a new and next pandemic arise. And I really hope it doesn't, certainly in our lifetimes here. And finally, to collect pedagogic material needed to educate the future generation of scientists in topics related to pandemic preparedness, recovery, and resilience. I think these are very broad goals. I think the questions that surround us through this pandemic are really, really very broad. Of course, direct questions related to response, but new questions related to education, to mental health, to long-term economic impact, the role of information. All these questions are going to be important, and today's workshop is going to hopefully shed some light on these topics. So with that, let me stop and hand over the floor to Lee and Erin again. Thank you very much for organizing this. I'm looking forward to this rather innovative way of doing things. I realize that people are tired of workshops often, but I think this will provide a very innovative platform for us to interact. Erin, Lee, over to you. Thank you.
Thank you, Erin. Thanks, James. Thanks, Madhav. So I'll just quickly kick off our session today. This data workshop is in fact the first of our workshop series. We have 3 workshops planned for addressing various issues related to pandemic research. Please visit our Prepare website for updates and more information. For the data workshop, we are really, really grateful to have a group of distinguished speakers joining us from academia, industry, and government, sharing their perspectives as a data provider, as a data consumer, as a data researcher. So we will have 4 synchronous sessions. As Erin mentioned, we do encourage you to join the live session. And also, if you can't watch the sessions, if you can't join live session, please watch the sessions and share your thoughts, share your questions, both in the session and after the session. And as a group, our goal is to really look at the questions related to the access and creation and the maintenance of the data resources to support pandemic research. So the questions that we are asking, and we want to, your thoughts and your opinions as audience, as a community as well, is some of these questions are: what data can be collected and shared and used? What are the hurdles to collect and share and use them to support pandemic research? And what technology, infrastructure, and policy operational mechanisms have worked well? What are the successes and what are the failures, and what are still needed? What are the key differences, if there's any, and issues for supporting the research use and operational use of the data? And what are the key privacy, security, and ethical issues for access, sharing, and use of the data? So together, our hope is we can understand these issues better and come up with a research roadmap that would help our community to pursue these challenges to better support our preparedness for the pandemic. For our session today, this morning, we will focus on the mobility, search, and social network data. And as you can see, we will also examine different types of data for the later sessions and the data curation sharing mechanisms. So for the session today, we are excited to have 3 speakers. We have Dr. Evgeniy Gabrilovich from Google Health talking about public health at Google. And we have Ingemar Cox Vasilis Lampos from University College of London to talk about the iSense response to COVID-19 surveillance using web search. And we have Alex Dow from Facebook talk about Facebook data for good. So without further ado, I would like to invite our speakers to share their thoughts with us and invite everybody to post your questions, to post your opinions and thoughts in the YouTube channel. Evgeniy, whenever you're ready.
Thank you, Lee. I think you need to stop your
I'll
presentation
stop my screen.
for me to be able to start mine. Can you see my screen?
Yes.
Okay.
Just a
Hi.
quick logistic question. We will address all the questions at the end of the 3 talks.
Okay, sounds good. Hi, everyone. So when we talk about preparedness for pandemics or mitigating pandemics, and we need data to sustain this process, we usually first think about clinical data collected at doctors' offices or hospitals. And today I will argue for the use of a new source of signal that we collect from users' online interactions with different products and services. I'll talk about the work my colleagues and I are doing in the public and environmental health team at Google, where we specialize in using signals that users generate while interacting with different Google products and services. We anonymize those signals, we aggregate them in privacy-preserving ways, and then we learn insights which allow us to contribute to improving public health. So some examples of this data would include web search queries. When users come to the Google web search engine, they issue search queries to satisfy their information needs, and we answer those queries. We provide the temporary links or we provide direct answers. In addition to that, we found a novel use for the signal where we aggregate and anonymize queries and we classify them to see what conditions are being searched for and what we can infer from those searches. In case of location visits, when people go to different places, if they choose to allow Google to record their location history, again, we can learn from the categories of places they visit. We aggregate those over entire counties or states, and we make inferences about what people do and why. In terms of economics, I would describe this as as an externality. There is a standard use of the data. People give us web search queries, we respond to them and satisfy the information needs. We also find the new beneficial use for those data points. So let me try to motivate this use of online signals with a metaphor of a funnel. Think about where data is collected today. It's collected either at doctor's offices when a patient feels bad enough to see a doctor, or when, God forbid, the patient feels so bad that the patient chooses to go to a hospital or is rushed to the hospital at the ER. This arguably happens much later than the onset of the disease. At the beginning, you don't feel anything. Sometime after the onset of the disease, after the incubation period, you start developing symptoms. So let's think about the possible universe of people experiencing symptoms. Now, some of them will develop worse conditions and they will need to see a doctor. Now, there is a very small fraction of people who sees a doctor for a variety of reasons. because they self-treat their condition at home, because the condition is mild, because they don't have medical insurance, which is especially important in the United States, or it is difficult for them to take time off work to actually see a doctor. So there are many people feeling symptoms. To be fair, a large fraction of them are searching the web for their symptoms because the cost of searching the web is exactly zero, and you get very timely answers from the search engine. And now the funnel begins to shrink dramatically. There is a small fraction of those people who will see a doctor or will undergo a test, and even smaller fraction of them gets to urgent care or is admitted to an emergency room, and even much smaller fraction of those is admitted to a hospital. So measurements at doctors' offices and hospitals see a much fewer fraction of people and much later. Think about coronavirus. You usually feel symptoms on day 3 to 5. That's when they suggest to get tested. And if you feel bad enough to go to the hospital, that's probably day 5. So we hope that with the use of online signals, we can provide a much earlier warning into what's going on on the ground. And I started with the universe of people experiencing symptoms. Of course, there are many people who do not experience symptoms, and we can use them as healthy controls. Again, we can observe their queries as well in the web search engine. Let me talk about a couple of studies we have done on this data source prior to the pandemic, and then I'll talk about our work on COVID-19. So before the COVID arrived, we worked on search and location data for 2 applications in public health. The work I mentioned on the left-hand side focused on foodborne illness, where people go to a restaurant, and in some of the restaurants, they eat bad food, and they have what's colloquially known as food poisoning, or medically known as foodborne illness. We used search and location data in the following way. In the majority of cases, foodborne illness is not life-threatening. You would stay at home for 2 or 3 days, just feeling poorly. And during this time, many people would search for their symptoms. We developed a query classifier of queries that are related to food poisoning. And for users whose queries were positively classified by this classifier as related to food poisoning, if they choose to allow Google to record their location history, would see what restaurants they visited in the days prior to the search. And then at the level of each restaurant, we computed a simple risk score. What fraction of people who visited this restaurant eventually searched for symptoms of foodborne illness. And this worked like a charm. It proved to be a very useful risk score. We conducted a prospective experiment for half a year with 2 big health departments in 2 US cities, Las Vegas and Chicago. Every day at 9 a.m., you would send them a spreadsheet of restaurants in their jurisdiction, ordered in the decreasing order of this risk score, and they would conduct a fully controlled blind experiment. They would assign inspectors to restaurants nominated by us and control restaurants, which are similar in many respects, but not nominated by our system. And after half a year, it turned out that 26% of the restaurants we nominated for inspection were shut down on the spot for just poisoning people. An additional 26% were cited for major violations and had to be re-inspected in a couple of days. What's more interesting is that in 38% of cases, it wasn't the last restaurant that was actually poisoning people. It was the penultimate one, or the one before, or the 4th one from the end. And I find it remarkable because usually a very small fraction of people would actually call the health department and would file a complaint. But when asked when you ate before your illness, they would primarily remember the last restaurant. And it is the power of this kind of online data that allows us to go further back in time and examine additional restaurants. Now, on the right-hand side, we focused on another health issues of public health significance, Lyme disease. Lyme is a tick-borne disease common in the United States, Canada, and some parts of Europe. And here we partnered with John Brownstein, who will be talking later today in the afternoon session. Again, we built a classifier for queries indicating research related to Lyme disease. We computed prevalence of Lyme disease according to the online data, aggregated and anonymized queries, and we compared it with what CDC knows. Now, Lyme is a so-called notifiable disease. By law, doctors have to inform the CDC and the State Health Department of the case they diagnosed. However, it's a very complicated system. Data gets aggregated at counties and at states and at the national level. So long story short, CDC has a best-in-class data, but it's quite delayed, sometimes as much as 2 years delayed. And we observed that with the online data, we established 92% correlation between the prevalence we see and the prevalence CDC knows about, except our data is 2 years earlier. Our data today can predict what CDC data will show in 2 years. And especially in rapidly evolving pandemics such as COVID-19, it is very important to shave as much time off the 2 years. And for us, it's hours, so at most a couple of days until the data propagates through all of our systems. And then COVID arrived. So when COVID arrived, we dropped all of our other work on the floor and we started working on COVID response. And today I'll talk about 2 projects we released last year: community mobility reports focusing on location data and the symptom search data set aggregating symptom search trends. So when COVID-19 arrived, let me take you about a year back in time, early 2020, there were no vaccines in sight, no masks, well, sometimes masks, and the main mitigation mechanism was social distancing. And around that time, government started to institute various social distancing policies, and many public health experts reached to us asking for help to understand how much people in different locations actually adhere to those policies and how they can improve their messaging to promote adherence. So in response to that, in early April 2020, we released a tool called Community Mobility Reports. And here I show a sample output of the system for the United Kingdom. So we identified 6 categories of interest: places of residence, workplaces, parks, retail and recreation stores, grocery and pharmacy, and transit stations. We counted the number of visits of people at each location, fairly fine-grained. We went down to state and county level in the US and equivalents of counties elsewhere. And compared to a reference baseline period in January and February 2020, we plotted how the visits changed over time. It was extremely interesting. So with the social distancing orders in place, people obviously visited many fewer places outside of their place of residence. So residential visits here go up, workplaces go down, transit stations were almost shut down. And it was very interesting to see what people on the ground do. And if you might remember, people were buying toilet paper like crazy. We actually see this. There is this small spike in grocery and pharmacy visits just before the majority of social distancing policies kicked in, because people wanted to stock on supplies and, of course, medications. So we released this data in 135 countries in fairly fine-grained resolution. It was used around the globe. The data was downloaded more than 41 million times, and governments used the data to study adherence to social distancing policies. World Bank and the finance ministries used the data later to forecast economic recovery. And by today, the data was used in almost 1,500 papers, according to Google Scholar, which cumulatively have been cited over 10,000 times. My colleagues and I partnered with the researchers in Harvard and Boston University to see how we can quantify the adherence to social distancing policies using our data. And then we try to correlate that with the case growth. So we found that the different policies enacted around the United States, in this case, were very effective. Usually, the mere declaration of state-level emergency caused about 9% reduction in mobility. And the variety of social distancing policies, such as closure of bars and restaurants, closure of various other businesses, resulted in a further 25% reduction in mobility. And shelter in place, which is the most comprehensive measure, resulted in an additional 29% reduction in mobility. We don't make any causal statements, but we did observe that every 10% reduction in mobility resulted in a subsequent reduction of 17% in case growth 2 weeks later. And we reported those results on arXiv, and they're going to appear in print in a couple of weeks from now in Nature Communications. So let me now talk about the symptom series data set we released last year. So here the data set consisted of 420 symptoms and conditions for which we plotted normalized search volume over 3 years, starting in late 2017 and until today. Again, we plot them at very fine resolution of US states and counties and the equivalents of counties in other countries. And today the data is available for the United States and 5 additional English-speaking countries. So in the remainder of this talk, let me briefly take you through several illustrative examples of the data. And then I'll mention the uses of this data in research papers. But first, let me motivate why we even wanted to release the data. So first, we hoped it will be used as a source of signal for predicting the spread of coronavirus, and it worked very well. Teams in the CMU Delphi group, our own colleagues in Google Cloud, and my colleagues working with Harvard and BU used the data to predict the spread of coronavirus better, and I'll talk to that as well. COVID obviously invokes direct suffering on people. People feel sick with the coronavirus disease, but it also forced people to be at home. Hospitals canceled all elective procedures, and many diseases started to grow because they were not maintained properly. People didn't refill medications, and predictably mental health and many other diseases exacerbated in the community. Now, the data sets themselves are much broader. They are motivated by coronavirus, but for example, the symptom search data set plots 420 symptoms and conditions. About 20 of them are directly related to COVID-19. Others are not. They're general symptoms and conditions that people can experience. And again, we hope this will provide an early warning or early window of insight as to what else can be brewing in the population to conduct studies and prepare for treating those sick individuals better. So let me take you through a few interesting examples I found in this data set. I'll start with anosmia, the loss of the sense of smell, which was highly publicized last year as a characteristic symptom of COVID-19. You might remember this symptom was publicized in a New York Times article published on March 23rd, 2020. And I plot here the data for New York in the yellow color and the data for all other US states in other colors. First, I wanted to show that when we report our data, so yes, we are not immune to news-induced spikes, and we obviously see the spike in the data. However, the news-induced spike subsided quickly, and the signal remained. The searches for anosmia were much higher than usually, and as I'll mention later, this signal was extremely useful, among the most useful predictors for the spread of coronavirus. When the mask mandates were instituted around the country, people started wearing masks, and they were uncomfortable wearing a mask multiple hours each day. And we saw a spike in searches for acne. So I show here two ways to analyze our data. On the left-hand side, you see a spike in the temporal domain around March, April, May last year. People searched much more for acne. On the right-hand side, I show the spatial view. Here we see individual US counties. The red color shows counties where people search much more than usual, and the green color depicts counties where people search much less than usual for a given symptom. As you can see, as we go into 2020, many more counties search for acne much more than usual, and both the temporal and the spatial views are available on our website. And you can, of course, download all the data. People were instructed to wash their hands like crazy, at least 20 seconds, multiple times a day. And sure enough, the searches for dry skin or xeroderma spiked in the middle of last year. Now, COVID obviously invoked a lot of adverse effects on the population, but there were some occasional beneficial effects, if I may call them this way. Travel was almost stopped. Visits to all kinds of gyms and sport places were stopped. People didn't engage in ski and other dangerous sports as much. And sure enough, you see a drop in searches for bone fracture. And since travel stopped, many fewer people search for motion sickness. Of course, the devastating effects of COVID were much more plentiful. You see searches for many chronic diseases such as osteopenia or searches for cataract dropped. And I attribute this to two causes. First of all, elective procedures were canceled and doctors didn't want to see patients unless there were critical cases in need of coronavirus treatments. So it was much more difficult to see a doctor than usual. And usually after visiting a doctor, people would also search the web to better understand what the doctor has told them. So if those visits didn't happen, people were much less inclined to search because they didn't learn anything from a doctor. And by and large, many diseases and conditions were neglected. People stopped refilling medication. They were afraid to go outside of their house. And you see drops in search, which are indicative of the problems being accumulating in the population, and they obviously need some resolution. Now, every data set we released was treated with differential privacy. It's a method that provides theoretical guarantees to make it virtually impossible to identify if a given user was absent or present in the data set. It's a very conservative measure, but allows us to release the data publicly. I won't talk much about it because tomorrow we'll have a talk by Salil Vadan from Harvard, which will focus on differential privacy. I just wanted to mention our use of the approach. And let me briefly talk about 3 uses of our data in different studies by research groups around the globe. Ingemar Cox, who will be talking right after me, is a worldwide authority of using search data for public health. Just as a quick disclaimer, this study I would mention used Google Trends, which is a resource which predated our release of the symptom search data. It goes to the level of US states, while the data we released goes to the level of US counties. Ingemar and his team received very interesting results in using the searches for a plurality of COVID symptoms, aggregating them in a simple way, as you can think about a stock index for a stock market. They aggregated a number of known symptoms and their weights based on the prevalence of the symptoms in the population, aggregate them together to construct one index of COVID-19, and that was a very powerful leading indicator of COVID cases, confirmed cases, and death counts later. Also, they have done similar work on controlling the effect of news. For example, they used the proportion of news media coverage on any given day that was devoted to COVID-19 as a proxy indicator of how much news coverage has been affecting the searches. And later, when they built a fully supervised model for predicting COVID-19, it was superior to simple autoregressive model. They just looked back in the previous days to see the COVID counts and predict the future cases based on that. And the addition of search data resulted in significant improvements and reductions in error. My own colleagues in Google Cloud built 2 models for predicting COVID-19. They focused on predicting the hospitalization rates and the death rates. They had 2 models, each using 19 features. Of those, 7 top features in each model came from the symptom search data set. For example, the number of searches for cough, anosmia, or fever turned out to be very good predictors. And finally, I would mention the study conducted by the CMU Delphi team. They used our data to improve their prediction. The prediction task was whether for a given hospital referral region, there will be a relative rise of COVID cases by at least 25% in the next week. They started with a simple autoregressive model depicted here in the red color, and the vertical axis shows the area on the curve for this prediction task. Then they added data from the surveys about experiencing symptoms of COVID-like illness, the light blue curve. The best results were obtained when using data from 2 sources, either medical claims about COVID illness or Google searches for anosmia and ogezia. Now, note that the medical claims are leading to very high performance, but the medical claims are somewhat delayed comparing to people who experience symptoms even before they interact with the medical system. Now, to be fair, I would like to mention one critical thing. Anosmia and dysphagia are extremely rare events. They were catastrophically rare before the arrival of COVID-19. They became more frequent because of COVID. As a result, the CMU team focused on 315 hospital referral regions. Of those, our data for anosmia was available only in 100 regions. The reason is the number of people searching for anosmia is still low. When we add differential privacy noise, sometimes the noise is so high because the number of searchers is so low that the noise has the risk of destroying the data. And in such cases, we withhold the publication of the data because it's going to be too noisy to be useful. So in those counties where in those places where the data is available, the results are very strong. As strong as with medical claims, but again, available much earlier in time. I just wanted to be fair and mention that the data is not available in every county. I would like to conclude my talk with a brief call for action. I would encourage you to use the data we are publishing in community mobility reports in the symptom search data. We will be happy to support your work and provide advice on the data set and how to use them best. And of course, please keep us posted about the ways in which you use your data, about the limitations you might experience or the successes you have. I'll be happy to take any questions you might have, but as Erin mentioned, we are not taking questions after each talk. We'll take them at the end of the session. And thank you very much.
Thank you, Evgeniy, for the great talk. We really appreciate the data sets that Google has shared with the community, and we've seen great evidence that these data sets have been used for great purposes. So that's also a great segue to introduce our next speaker, Dr. Ingemar Cox. He is a professor in the Department of Computer Science at University College London and a deputy director of the iSense project on early warning sensor systems for infectious diseases. And I believe he has been using some of the data that Google has released and working with Evgeniy. So Ingemar, whenever you're ready.
Just taking myself off mute. Hope you can hear me.
Yes, awesome.
And can see the slides.
Yes.
Okay, then I'll begin. Well, thank you very much for inviting me here to give a talk today. I'd like to talk about the iSense response to COVID-19 surveillance using web search. This was work that was led by myself and Bill Lampos, but involved a number of other people who I hope will acknowledge during the talk. Oops, why isn't that? There we are. So I just wanted to talk about what iSense is first of all, and give some context to what we've done in response to the COVID-19 pandemic, and then I'd been asked to talk about what were some of the issues that we had to face and what we would like to see in the future. So let me begin by just explaining that iSense is an interdisciplinary research collaboration that's funded by the EPSRC, which is the UK's equivalent to the US National Science Foundation. And the remit of iSense is to develop a next generation of early warning sensing systems for infectious diseases. And it's a big collaboration that began in 2013 and is still ongoing. That's led by UCL, but involves in Imperial College London, Newcastle, London School for Hygiene and Tropical Medicine, Surrey University, Strathclyde and Glasgow, as well as Public Health England. And Public Health England is England's equivalent to the US Centre for Disease Control. So, as I mentioned, this is a really large multidisciplinary effort. It involves epidemiologists, infectious disease experts, chemists, nanotechnologists, computer science. I'm just going to see if I can just remove, sorry, I'm having well, never mind. I can't seem to remove something that's in the side of my screen here, which is blocking some of my slides. But it's also involved, of course, computer science, behavioral psychologists, and ethicists. I am a deputy director within iSense, and I lead the track theme within iSense. So we're a big network with many partners. We have partners in lower middle income countries, and some of the work we did with COVID involved work with South Africa. We have a large number of clinical partners, a number of National Health Service trusts within England, as well as quite a few industrial partners. So a lot of our work, ours being Bill Lampos and myself's work, as opposed to iSense generally, which is much, much bigger, is focused on digital epidemiology, which Marcel, who I think is giving a talk in the next session, described as epidemiology that uses data that was generated outside the public health system. In other words, data that was not generated for the primary purpose of doing epidemiology. And the kind of data, of course, that this involves is of course web searches that Evgeniy just mentioned, but also involves analysis of Twitter data, Facebook data, blogs, mobility data, which again Evgeniy touched upon, but as well as mobile phones, there's also transit system data, and then retail sales of over-the-counter medications is another interesting source to look at. And there's many other ones as well. Evgeniy touched on why the answer to this question, which is why use data that's generated outside the public health system. And so I won't really focus too much on this, but as Evgeniy pointed out, there's a potentially much larger sample of the population that we can reach using these systems. They're often complementary sample from the traditional healthcare data. So with healthcare data, you're seeing episodic samples from individuals only at times where they're ill, whereas these samples can almost be continuous daily samples, and of course from the non-health-seeking population, which hopefully is usually much larger than the health-seeking population. I think we've demonstrated that potentially very useful at the start of a pandemic when traditional testing for disease is really quite limited. So we've done a number of projects within the context of digital epidemiology. We've looked at monitoring mass gatherings for infectious disease outbreaks. Mass gatherings are, for example, large music festivals that last for days, big religious gatherings such as the Hajj. Oops, I've touched my screen and gone out of full screen. There we go, let's go back. We've looked at using Twitter data to estimate secondary attack rate and serial interval for influenza. So secondary attack rate you can think of as how infectious is the disease. Serial interval, how long does it take between one person getting it and the next person getting it. We've looked at effectiveness of public health interventions like vaccinations, which contributed to the rollout of influenza vaccinations for children. The NHS now approximately gives 5 million vaccinations a year, which they estimate reduces influenza in the general population by about 20%. And that general population doesn't have to have had the vaccine, just a general reduction by 20%. And then, of course, we've done infectious disease surveillance. In that regard, we've done a lot of work in looking at influenza surveillance. We started doing that around 2013, and one of the reasons why we focused on influenza surveillance was that I think other countries as well, but certainly the UK government has a risk register, and they had identified pandemic influenza as highly likely to occur over the next 10 to 20 years and at a very high cost to the country. And so we were strongly encouraged to look at influenza surveillance in view of potential influenza pandemic threat. So certainly we were aware of the possibility of pandemic, of course. We just got the disease wrong. But I think the work that we did here really helped us in responding to the COVID-19 pandemic. But this work is based on supervised learning using deep learning models. I'm not going to go into detail about how those models work, but they effectively give a 1 week lead over traditional surveillance for outbreak detection. And Public Health England collaborated with us on the development and assessment of these. And after several papers which looked at assessing it over several years, since 2017, they've incorporated this as part of their influenza surveillance network, which includes many other sources of signals and feeds it in and is reported in their weekly influenza reports, which they publish during the flu season and which are used to inform decision-making within the England Health Service. So it was probably, partially because of that collaboration that Public Health England asked us to repurpose these methods for COVID surveillance in early 2020. That actually turned out to be quite difficult in that it wasn't the main difficulty, and one we've been aware of for a couple of years, is that almost every algorithm that you look at for doing surveillance based on Twitter, web searches, etc., use supervised learning. And the problem that we have with a pandemic is that there's no or very little supervised learning data to be used. And so we had to develop an unsupervised learning model, which, as Evgeniy explained, used weighted symptom terms that we originally recovered from the NHS. These graphs on the left sort of show outputs for various countries. The US is the top left, UK the top right, but there's results for Australia, Canada, France, Italy, Greece, South Africa. You may just discern a dotted vertical line near the peak of these scores. That's the time at which each country introduced some level of social distancing or lockdown. And you can see that these scores drop substantially thereafter, which at least you can think of here as a qualitative indication that what we're measuring here is due to COVID prevalence. After developing this, we were asked to look at regional anomalies. So this the previous slide was looking at England nationally, but Public Health England now wanted to look at subnational regions, healthcare regions, and try to identify any region that was having an anomaly where they needed to maybe do local lockdown, for example. And here we work quite closely with Microsoft using Bing's search queries at the subnational level, and developed techniques that were very similar to some of the earlier work we did on measuring the effectiveness of vaccine programs, but where we were able to show up to 3 week lead time on, for example, mortality using these at a local level. And again, Public Health England has incorporated this data into their weekly reports at a subnational level as well. So that's the sort of context of what we've done in this space. Let me sort of now talk about some of the difficulties and barriers that we had. I'm sort of hesitating a little bit about thinking of it as barriers, because what I want to talk about are legal and ethical issues, and there are very legitimate and important reasons why there are legal and ethical concerns with this work. But from a legal perspective, what we encountered were maybe three main issues. One was interpretation of terms and conditions for the use of services on the web and collecting data. And I'll give an illustration of that with respect to Twitter data, although I'm just using that as an exemplar. Twitter aren't the only web service where there's ambiguity in terms and conditions. We also observed sort of delays due to contractual negotiations, again, where we were purchasing data or even being given data by certain companies. We experienced considerable delays due to contract negotiations. And then, of course, there's restrictions in data sharing, which I won't go into a lot of detail about, but again, in some cases, these restrictions are there for very legitimate purposes, particularly in the context of advertising and competition, but maybe are not particularly appropriate in the context of public health. So this is just some of the text from the Twitter developers' terms and conditions as illustration of some of the ambiguity that we have in the terms and conditions. And it basically states that you may not use Twitter for the purpose of conducting or providing surveillance or intelligence gathering. Now, my interpretation of that is that they're not really talking about public health surveillance and intelligence gathering for public surveillance, but there is an ambiguity there. It later goes on to say that we cannot monitor sensitive events. So this raises an issue about can we monitor mass gatherings for COVID outbreaks. And then lastly, it prohibits the use of targeting, segmenting and profiling individuals, particularly based on health or ethnicity. Now, clearly, there's very, very valid reasons for these limitations, but I think many of them were not thought of in the context of how Twitter might be used for public health purposes. So, for example, we might be quite interested in ethnicity in response to studies about vaccine hesitancy. The terms and conditions here leave it rather unclear about whether we could legitimately do that. This is a last part which states that you are prohibited from inferring or deriving information about a Twitter user's health. If a Twitter user, and there are many that do this, tweet, "I've just been diagnosed with COVID," or "I've got COVID-19, is there any inference going on there? So these terms and conditions are unclear, and clarification, in my opinion, is somewhat problematic in that I don't think it's resolvable just by a quick conversation with the legal department of the company involved. In that the legal department, again, in my opinion, does not necessarily represent the interpretation of the leadership of the company. And in some cases, the legal department is solely focused on minimizing risk and not looking at any reward from the company or for public good. So there are issues there about how to resolve these ambiguities in terms and conditions. Companies quite rightly make judgments about assessing risk and reward. And I think when it comes to data sharing, we need to think about how do we reduce risk for companies and how do we increase reward? I think increasing reward for me seems quite difficult to do in that many of the companies that that have this kind of data are billion-dollar companies where the kinds of funds that universities and research organizations in general, government research organizations in general could bring in monetary value is actually very small compared with the revenue of these companies. So we really need to think perhaps more about how to reduce risk for these companies so that they are more eager to help. Not that they haven't been helpful. There, of course, Evgeniy mentioned some technological solutions, which I think show a great deal of promise. I think, though, also it's worth considering legislation that possibly indemnifies the company in certain cases where their data is used for public health purposes, particularly in the case of a pandemic. So from an ethics point of view, of course, a lot of our work does raise very interesting ethical issues, and it's important to make sure that we have an ethics review and that we maintain the public's trust. We did experience delays due to ethics approval. It's unclear whether this experience is general or specific to our own applications. Surprisingly, Twitter posed the most challenge from our perspective. Those issues included interpretation of Twitter's terms and conditions, which I've previously discussed, but it also involved informed consent. So in our discussions with our ethics committee, it was generally agreed that Twitter users, by accepting the terms and conditions of Twitter, have essentially agreed and made informed consent. However, there was what's called indirect participants. So if you're a Twitter user and you tweet that your spouse has COVID, it's quite unlikely that your spouse has made informed consent to that piece of information. And so this was another ethical issue that we had to discuss. So lastly then, how should things be going forward? I'm not sure. We did publish a very short correspondence at the beginning of March of last year. And within that, we were urging technology companies to work with researchers and governments to share data rapidly, but of course in legal, proportionate, ethical, and privacy-preserving manner. And we also asked governments and funding organizations to create new centers of digital public health to deploy and evaluate proven innovation. Companies did indeed share data. I think there were issues which I don't blame the companies for, about possibly what they shared and what we wanted, and about the timeliness of when we wanted it and when they could provide it. And I think those issues need to be thought through a little bit more deeply about how we could reduce the differences in time and the requirements. I also think that that funding public these centers for digital public health is quite important. I wanted to just end the talk by just noting that the response to COVID-19 pandemic has been multidisciplinary, of course, and I think the contribution of computer science and engineering in general has been very strong. But preparedness will require new multidisciplinary solutions that involve medicine and healthcare, of course, science and engineering, and law, ethics, and policy. And I'm making those points to say that when we talk about data access, creation, and maintenance, I think it would be useful to listen to the medicine healthcare community about what data was useful to them, inferred data was useful, and also to think not just about technological solutions to key problems such as privacy, but possibly legal and policy issues as well. And then, as I said before, I think there really is a big requirement for a sustained long-term funding for these digital health centers. Thank you very much.
Thank you, Ingemar, for this great thought-provoking talk. You raised many important legal considerations and risk and reward considerations associated with data sharing, especially when we are considering digital epidemiology, as you mentioned, using data not generated for public health initially. And I really like that when you say how things should be going forward, we're not sure. So that's why exactly I think we're trying to bring the community together and discuss these issues and map out the best path forward. So next, we will hear from the perspectives from another company, Facebook, in terms of their data sharing effort. And we will welcome Alex Dow, who leads the interactions data team, I believe, who's involved a lot with the Facebook data for social good. So we will hear about these efforts from Alex. And as a quick reminder, if you're watching this live or if you're watching this post live stream, please post your questions on the YouTube chat or comment box or on Twitter at NSF-prepare.
Great.
Alex.
Yeah, thank you, Lee. And thanks to all the organizers for having me here and to the other speakers for the great presentation so far. Really looking forward to the discussion that follows this. Yeah, I'm Alex Dow. I'm a research scientist at Facebook, and I work on this program called Facebook Data for Good. And that's what I'm going to talk about today. So the general idea of this program is similar to some of the stuff Evgeniy described for his work at Google. The idea is to really leverage Facebook data and technology, as well as expertise that we have in the company, in ways that can empower NGOs or researchers for social impact, while preserving the privacy and security of Facebook users. Obviously, this workshop is focused on pandemic response and resilience. I'm going to kind of overview some of our offerings in this space. Now, our program goes beyond just disease response and recovery. There's also applications related to crisis and natural disasters, climate change, gender equality, and other things as well. And we'll find that a lot of these issues really kind of cross between, or the offerings we have kind of cross between issues and can be useful for multiple applications. Yeah, I think Dr. Cox highlighted like a bunch of really compelling issues related to data from private companies for pandemic response. And I really hope to get into a lot of those in the discussion. I thought it'd be useful to frame that discussion by giving an overview of some of the offerings that we have and data sets that we're sharing through this program. And I'll try to kind of hit on some of these topics of privacy, security, and efficacy as I do that. So on here, I have a link for our website. I suggest checking out after the workshop's over, dataforgood.fb.com. On that website, they discuss each of the data sets I'm going to talk about here today, as well as many others. Yeah. So the first data set I want to mention is what we call movement range. So this is kind of similar in some ways to the Google Community Mobility Reports. This was a data set we developed during the pandemic in response to these questions about the role of mobility and the changes in mobility as reacting to public policy related to mobility restrictions or shelter-in-place orders. So before I get too much into it, I think it's useful to talk about what the source data is here. And so on Facebook, there is a setting for users called location history and location services, where users can opt in to share precise location data with Facebook, which can then be used to enable various features in the products. And one of those features is data to be used for this data for good purpose. The idea being that it would be taken and used in aggregate in privacy preserving ways to address these social issues. So basically, it's important to think about this being not just Facebook users, but a subset of Facebook users that share this precise data. And so a couple of the data sets I'm going to talk about today rely on this sort of like precise mobility data. So these movement range maps, like I said, are meant to give insight into changes in mobility related to pandemic restrictions. One way of looking at this is on a time series like shown here. This is the change in mobility for the first few months of the pandemic in each county in California. Each yellow line shows a measure of that mobility change for an individual county, while the gray lines behind it show all the other counties for comparison in California. So this particular metric is showing, just to get a bit into the weeds technically on how this is computed, we use a grid system, Bing tiles, over the entire globe that breaks up the world into basically 600 meter by 600 meter tiles. And so each individual, you can think of their mobility. One way of quantifying their mobility is how many of these tiles are they observed in a single day. And so what this data set does is takes that measure of each person, aggregates it on average for everyone that lives in that county, and says, how much are people moving around in a given day? And this particular metric actually compares it to a pre-pandemic baseline. The idea is each day of the week or throughout the year, are naturally going to have fluctuations in mobility. So by comparing this to a baseline, we can really see not just how much are people moving around, but how much is it different than before the pandemic. And so if you really kind of squint at this and look at it, you can see the effect of particular local and statewide orders, as well as just general behavior change. Another way to look at this is in like a map form, where we can plot over time how mobility has changed. And here we see, again, the first few months of the pandemic in 2020 in Europe. And when it starts over, you'll kind of see that it really kind of hits Italy first and spreads to several other countries. The metric here is a little different than the one I just described. It's a little simpler. We call it stay put. So again, we use this tile system. But instead of saying how many tiles are people moving around in, we say what fraction of the population stayed within just a single tile on a day. Now, naturally, even in shelter-in-place orders, there's going to be a lot of reasons people move around. But we found that in aggregate, looking at the fraction of the population, of our observed population that does stay within a single tile in a day, was very indicative of adherence to these sorts of orders. Now, this data set, I guess I'll go back just so you can see the links to it. This data set we make publicly available. So it's on the United Nations Humanitarian Data Exchange. And in order to enable that, similar to as Evgeniy was talking about with the Google data sets, we do employ differential privacy. So it sounds like with this audience, I don't need to go into too much detail on the specifics of how differential privacy works, but the idea is it provides theoretical guarantees that any individual's presence or absence in that data set cannot be determined, or would be very difficult to determine, therefore protecting the privacy of any individual. This is updated daily, and yeah, you can download it. It's produced for the entire world at the level roughly equivalent to the US counties. The entire world with some notable exceptions. So moving on, another data set I want to talk about is what we call co-location maps. This is another data set that was released during the pandemic. It's got a very different purpose. While the movement range was really focused on understanding the effects of policy on people's behavior, the idea with co-location maps was how can we build a mobility data set that would be most useful for parameterizing metapopulation models. So epidemiological models that can be used to predict the spread of a disease. So again, this uses that same source data, the location, precise location data from users that have opted into location history sharing. And so basically, let me tell you a bit about like what this is and how it's computed, and then I'll talk a bit about what it's useful for. So my pretty background that I'm using for all of these slides is a visualization of the co-location maps. So the idea here is basically that when parameterizing these models, it's useful to understand how people from different places mix together. And so what we look at here is basically measuring probabilities between places. In this case, these US counties are equivalents around the world in a similar size region. The probability that people from different regions are co-located at any given time during the day. So when we say co-located, we mean, again, these kind of 600 meter by 600 meter tiles, how often a person from each of these places is within one of those tiles together within a 5-minute window. So maybe to make it a little more concrete, I live in California in the Bay Area. So maybe we want to say, what is the co-location probability between San Francisco County and San Mateo County? So a co-location would occur when someone from San Francisco County maybe is in San Mateo County, co-located in close proximity to someone from San Mateo, or someone in San Mateo is in San Francisco County. Although this could also happen if a person from San Francisco and a person from San Mateo are co-located in a third place, maybe in Alameda County or in one of these small tiles. So we measure this empirically within this population that we have, and then compute what's basically a matrix of these probabilities between all pairs of locations. So what we found is, and actually, yeah, so while this map that I'm showing you is a kind of a pretty way of looking at the strength of these ties, this one's less pretty, but a little bit more informative. So here are an illustration of co-location probabilities between regions in Italy. So we basically colored them or labeled them in 3 different ways. The light gray indicates like a lower co-location probability. Blue is like an intermediate co-location probability, and red is a higher co-location probability. So with gray, you kind of see these lines all over the country. And so it's not surprising that there's some small level of co-location among people between pretty much every pair of locations. While the red lines, you'll notice, where these high co-location probabilities are really when mostly occur between places in close proximity or that are adjacent to each other. So that's not surprising that you're most likely to be co-located with people from regions that border the region that you live in. Now with the blue, these kind of intermediate range, you see a lot more kind of interesting ties where there will be some regions that are in close proximity to each other, but also regions that will be more far-flung. That for one reason or another tend to have like higher levels of co-location that you would see otherwise. Now, this data set, we also use a variety of techniques to protect the privacy of individual users, including aggregation. We omit any sparse regions, any regions without like at least a certain number of people. And unlike the movement range data, which is shared publicly on the Humanitarian Data Exchange, this data set does have restricted access. So as part of our Facebook Data for Good program, we have a data sharing agreement and a vetting process for organizations, NGOs, and researchers to go through to get access to our most sensitive data sets. And so this is one that's behind that restricted access. Now, I shared the website. If researchers or people that representatives of organizations want to learn more and get access to these data sets, you can find more on that website or reach out to me personally. Hey, Lee, how am I doing on time?
I think it'll be good if we can wrap up in 5 minutes, so we leave some.
Okay, cool.
Questions.
So I just kind of prepared like a litany of these, so I'm just going to kind of keep going. If we don't get to all of them, I'm happy to discuss more in the discussion section. But I wanted to kind of call out some other data sets that were not as restricted to looking at human mobility, mostly because I think they kind of highlight some of the other issues of pandemic preparedness and response that are less about maybe the spread of disease itself, though can be. So the next data set I want to talk about is called Social Connectedness Index. Now, while, like I said, the other data sets we looked at were about mobility and using this precise location data, the Social Connectedness Index uses Facebook friendships. And so, which is at the core of what Facebook is and Facebook data. So the idea here is that under the understanding is, first of all, just social ties generally can be useful for understanding things like disease spread, peer influence, or economic mobility, as well as a number of other issues. And that aggregating Facebook friendships can actually provide a useful proxy for the strength of these ties between different regions. So this index, let's see, what do I have? Okay, maybe before I get to that, I'll just say that we compute an index basically by looking at the strength of ties, the number of Facebook friendships between different regions. Again, this is done at like the county equivalent, though we also do it at the country level, and create an index that can be used to kind of measure this and actually compare between places. So this map shows an example of the social connectedness index for San Francisco County. So here, this is the connection between San Francisco the people in San Francisco and the people in each of the other colored regions on here. Now, the darker blues tend to show stronger social connectedness, while the lighter greens show weaker social connectedness. And so kind of similar we saw with co-location, there's a lot of dark blue in California. So people that live in California tend to have like strong connectedness to other regions in California, in the US West, and also places on the East Coast, as well as places in Europe, Australia, and Asia. And then we'll see there are other regions with less connection. We can also look at this at the country level. For example, with India, we'll see that some countries such as like Canada and the Middle East, other countries in South Asia and Australia will have these stronger, darker blue connections, while some will have lighter green. So the idea, again, is that this data can provide a useful proxy for the strength of social connections between these places. We've seen this used in the pandemic for understanding things like peer influence. So the influence of ideas related to adhering to social distancing protocols or mask wearing or things like that. But yeah, I think the applications of this go beyond that. Oh yeah, also in terms of like privacy and access, this data set is also protected by differential privacy and is publicly available on the Humanitarian Data Exchange. Okay, this one I wanted to call out because it's the newest data set that we released just a few weeks ago, the Relative Wealth Index. The idea here is that it's important to understand how wealth and poverty are distributed at a fine granularity in the world. And in terms of pandemics, I think this is really important data for understanding things like equitable vaccine distribution and kind of beyond the pandemic development programs. This is also something that's particularly useful for us in terms of understanding the bias in our Facebook data sets. All the other data sets I've talked about are based on the data and the distribution of Facebook users. And if that distribution is not representative of the underlying population, that could lead to unrepresentative conclusions drawn from it. So having good data about good fine-grained data about the distribution of wealth and poverty can be useful for understanding and removing such bias. Now, I don't have time to go into the detail too much, but the basic idea here is taking gold standard home survey data. So if you look at this map of Nigeria, all these blue dots on here are where actual, like there's gold standard home survey data that includes information about wealth and poverty. And then using machine learning methods and non-traditional data sources, things like satellite imagery, road density, also like internet connectivity, the quality of people's phones or the quality of their connection to the internet, as well as like demographic and other variables. And using this to create models that can make out of sample predictions about the relative wealth within an area. So where people are wealthier versus not within like a particular area. And these estimates are made again on one of these tile systems, but at the level of about 2.5 kilometers by 2.5 kilometers. So I really recommend checking this out. There's the paper, the preprint here by researchers at Facebook as well as UC Berkeley. And let me just wrap it up with one more and just make a plug that the pandemic is not just about, as we've all come to learn, is not just about medical issues, but this affects many parts of our society, including the economy. And so to kind of help provide signals into the effect of the pandemic on the economy, we've developed this data set called business activity trends. So the source data here is activity from business pages on Facebook, how often they post or how often they're visited. So this data set is based on research from Eyre et al. At University of Bristol. They had a paper in Nature Communications using Facebook page data to understand recovery from natural hazards or natural disasters. So we've worked with them to develop this and expand it and also apply it to the pandemic. And that the data set right now is focused on the pandemic, though we're looking to expand it to, dynamically to hazard events as they arise. And the idea here is to look at how activity on these pages changes over time And the work by Ayer et al. Show how that can provide useful signal into the effect of the disaster on the economy, and then also its rate of recovery. And so here we'll see some of these aggregate trends in Facebook page data for different cities in the UK during the pandemic. The dashed line here is when lockdown restrictions were instituted. We'll see that there's a buildup prior to that, as well as like a big fall when it happened. We can also break this down by different sectors. This is not a great figure, but the thing I'd take away from it is that in the upper left corner, this is kind of like, this is for California. This is kind of like the general trend. Again, this is the first few months of the pandemic. The red line is the statewide lockdown. We'll see this kind of like effect on all business around the time of the lockdown and actually preceding it, where there's a decrease in this index. But in the bottom second from the right, we'll see in the restaurant sector appeared to be not surprisingly more impacted. So this data set also, we protect the privacy of pages as well as people's activity with aggregation. We omit sparse regions, and there is restricted access to this. So that was my quick overview of a few of the data sets we've released recently related to the pandemic. Happy to discuss all of the issues related to these in the discussion, and one more plug to visit our website. Thank you.
Thank you, Alex, for the great talk and the sharing of the great data resources. And I want to take this opportunity to thank all our speakers for this session. This is really great. We've seen from both the data providers, the private companies' point of view, and the data researchers' point of view. On behalf of the community, we really appreciate the data sets Google and Facebook and many other companies have shared with the community. As we have seen from Dr. Cox's research, and I believe many others' work, these data provides complementary data sources to the public health data and allows better and more comprehensive and sometimes even earlier modeling of the pandemic. And of course, we have seen many of the complex considerations and challenges in sharing this data with the research community as well. The first of all is probably privacy. So both Evgeniy and Alex talked about using differential privacy mechanism in your data sharing process. And there are several questions from the audience related to the use of differential privacy. And of course, thanks to the audience who have posted questions, and we invite you to continue post your questions on the chat box and in the comment box. And Evgeniy has already addressed some of the questions in the comment box, and we have our speakers, they will engage with us during the asynchronous session, so they will answer some of those questions in the comment box, even if we don't get to it in the live session. But so for now, for the live session, I want to ask a few representative questions related to the use of differential privacy. I think, first of all, the question is probably applicable to both Evgeniy and Alex. Both of you use differential privacy. And the audience, some of the questions, they wanted you guys to talk a little bit more about regarding your experience in terms of the trade-off you have made between the quality of the results or the data that you share and the privacy protection and the number of queries and so on. So that's the first question. And secondly, the related question is, did you guys account for correlation over time when you release the data in terms of the sequential composition? For example, people may go to the same stores multiple times. Do you consider that in your data release?
So I'll be happy to start. For the first question, which asked about the different trade-offs, the way we work is we consult our colleagues specializing in privacy, and we receive a so-called privacy budget, which at the end of the day translates into the value of epsilon. It's a parameter to the differential privacy process, which prescribes the amount of noise we are adding at different levels of granularity. Then we apportion this budget, in our case, at 3 levels: national, state, and county. The lower the level, the larger the chunk of the budget we use to be able to add less noise when the data is granular. Otherwise, the noise will just destroy the data. We treat the user privacy at the utmost value, and in some cases, we do understand that the amount of noise we add will dwarf the value or will render the value unusable. To this extent, we build a predictive model which estimates the likelihood of the noised data to be within certain intervals of the true data value, And if we predict the probability is too low, that the noise value will be close to the actual one, we remove the data point. So in some cases, you don't see us reporting data points for a given location, and that's for one of the two reasons. The less likely reason is there are no searches at all about a given symptom or condition or visits to a particular kind of place. The more likely reason is those data points are so scarce and so few that the amount of noise we have to add to really guarantee indistinguishability of the users makes us remove the data point. The second question about the correlation, so to implement different, if I understood correctly from the comment posted on YouTube, the question was about multiple data points from the same user. So to implement differential privacy, we limit users' contribution to the same category as well as to multiple categories. So for example, in the case of a symptom search, we allow up to one query from each user to contribute to a given symptom, and for the user to contribute to maximum 3 different symptoms. And we use similar contribution thresholds for the location-based data set. And we ignore all other contributions, again, to make sure the users are indistinguishable. As a consequence, there was no real manifestation of correlation because we imposed fairly low contribution thresholds. The lower we put those thresholds, the less noise we have to add to mask the presence or absence of any user.
I see. Thanks, Evgeniy.
Yeah, I think well said. And yeah, I don't think we need to repeat some of the similarities in terms of having a privacy budget and Epsilon that distributes these things. One point I'll make is that some of these data sets are more challenging to apply like a straightforward differential privacy approach to, and in some the efficacy can be more impacted by the addition of that noise, especially the level of noise you'd want for to meet under these budgets for public release. And this is where we have this kind of restricted access class of data sets, where we also have various privacy protection mechanisms in place, but maybe without the limit of the same budget. And those are shared with basically restricted sets of trusted partners.
Mm-hmm. It's like multi-tiered access to the data.
Yeah.
Some of them are public, some of them are with restricted.
Yeah, and I think we strive to make things as accessible as possible and make data sets as widely available as possible and as many public as possible, because we found that can empower like a lot more usage by a lot more people. But like you said, there's a trade-off, and sometimes by having this tiered access, it allows us to move faster and get data sets out into the hands of some people faster than we would otherwise if everything was gated on what was required for a fully public release.
Mm-hmm. Thank you, Alex, Evgeniy. So in the respect of the time, we have more questions, but I will just ask one last question. I think that's very important for all of us. So this question, I think both can be addressed to Dr. Cox in terms of using the data, and also to Alex and Evgeniy in terms of releasing the data. So can you guys talk a little bit about how to deal with the issue of bias and fairness? So Dr. Cox, when you are using the data, how do you deal with that? For example, subpopulations who may not be well represented in terms of the data and other related issues. And Alex and Evgeniy, for example, some people may not use Facebook, so the data is naturally biased. So how do we address these issues?
Sorry, just taking myself off mute again. I mean, in much of our work, we haven't addressed that directly, to be frank. Of course, I could pass the buck to Evgeniy and say, well, we're using but more seriously, I think it's helpful, at least for the systems that are utilised by Public Health England. They're just one of many surveillance systems. I mean, they don't rely just on us to estimate COVID-19 prevalence or influenza prevalence. And the Sentinel doctor networks, there's data from ICU PCR testing, and other data sets, which hopefully within Public Health England can also, consider, representational bias, for example. But for us, specifically in our own signal, we haven't given that a lot of consideration. And in part, I think it's difficult for us to do that, particularly in a machine learning area where we would need, supervised labeled data from different communities. And to the best of my knowledge, it's not available.
I'll be happy to address this. It's definitely a very important question of how representative the data is, which we publish and in which public health decisions are made. We are currently studying this very question with my colleagues. Understandably, in different places, the degree of representativeness will be different because different fractions of the population use Google for a variety of causes, because they are not as well versed with technology, because English is not their primary language, because they don't have access to the internet or the device which provides access to the internet. And we are interested in quantifying this degree of representativeness. We'll be using standard census data as a reference point. We don't yet have results to report, but I hope to have them in the future. Thank you.
Thank you.
Yeah, I'll pile on. Yeah, this is a huge question and something we've been talking about as long as, and it has come up as long as we've been working on this Data for Good program. Obviously, not everyone uses Facebook, and not everyone uses Facebook the same way. And like I said, some of these data sets have even more bias in them because only subsets of users would be included based on their behaviors. So we kind of got multiple ways of approaching this. One is that we expect, especially when working with trusted and vetted partners that we're sharing data with, we expect this to be just one signal among many that are used to make decisions, especially like policy decisions, and that a process of triangulation occurs where there will be bias in our data, and then they understand that the source of that bias, and then other data sets will have other bias, and hopefully this provides a useful signal that can inform decisions without being the sole source of truth about what is going on the ground. Now, even better than that is when we can do bias correction on our data sets and make them more representative of the underlying population. Now, there's going to be limits on that. If there's coverage issues where there are populations that aren't present in our data at all, it's impossible for us to say anything about them. And so it's really important to understand where that's happening and call that out. But in terms of bias correction, I mentioned the Relative Wealth Index, which is a data set not based on Facebook data, and it will have its own biases, but not based on Facebook data generally, though there are some features related to Facebook that go into the calculation of the model, that should provide useful information for everyone to understand bias in their data sets when it's related to the distribution of wealth and poverty. Another data set I didn't describe today is what we call the high resolution settlement layer. So this is an extremely high resolution population density map for the world. This data set can also be a really useful tool, and one that we use to understand bias in our data sets and how our population differs from the population on the ground.
Thanks everyone. Those are great insights. I know it's a complex problem. So that's why we need to work on it as a community. And I know I said that was the last question, but I really have this also another burning question. So I'm going to abuse my privilege to ask one more question, which is, so this digital epidemiology, as Dr. Cox mentioned, we're trying to use this data not generated for public health initially. And as a community, we probably want to also think creatively what data can be used. So for Dr. Cox, I want to ask you, what is your wish list? So what data do you think are most useful? Or are there any data that you wish you have access to that you don't have access to? So we can ask Alex and Evgeniy to release more data, right? And a question for Alex and Evgeniy is that, how do you decide what data to release? You guys mentioned a fantastic set of data sets. So what, in your experience, or what experience can you share with other companies who may actually have other type of data that may be useful for the community, for the pandemic research.
This is Ingemar. Well, we always want finer grain data. And of course, there's always that conflict with privacy and security.
With no noise added, right?
Exactly, and I understand the tension there. Yeah, maybe I should stop there.
So speaking of the resolution which Ingemar just mentioned, historically for the datasets we released last year, we provided data at the level of US counties and equivalents in other countries. We hope in the future we might be able to provide finer resolution at times. Some examples could include zip codes or census tracts in the US and maybe equivalents in other countries. With respect to how we decide on what data to release, we actually consult very extensively public health experts. We are lucky to have some of them at Google, but we go way beyond Google and consult many experts and officials outside of the company in multiple countries to better understand what's valuable for them. They're the ultimate consumer. We make the data public for transparency, but we seek subject matter experts' opinion into what would be valuable, kinds of data, and how to process the data to make it most valuable and actionable for them.
Mm-hmm.
Evidently there's a vacuum going on in the background, so I'll keep it short. I'll just say similarly, one of the strengths of our Data for Good program is that we have this partnership model where we have these subject matter experts and particularly like practitioners and NGOs that are acting on the data that we have. And they are a really valuable source for finding, what are the most pressing problems and the biggest data gaps that we can help address. So we basically use this partnership model where there are subject matter experts and practitioners, researchers like me and people on my team at Facebook who are really more experts in Facebook data and what we can do with that data and the techniques we can use on it, as opposed to the particular problems we're working on. And then also privacy experts within the company that deal with and help us understand the privacy implications, security implications, and ethical issues related to data use. So all that combines together to really kind of usually form a plan of what are the biggest needs that we think we can address in the near future and what we should prioritize.
Thank you, Alex. Thanks, Evgeniy. Thanks, Dr. Cox. So we are running out of the time. I want to take a minute to thank all our wonderful speakers for the great talks, thought-provoking talks, and again, all the resources of the fantastic data sets. I also want to thank Dr. James Joshi for supporting the virtual organization, for supporting this great community effort, and thank the program committee for the great help in making this workshop possible, and everybody else who has helped and made this possible. So we are done with the live session, the first live session, but of course the discussion doesn't and shouldn't stop here. We invite you to post your questions, post your thoughts on the comment box, and the speakers will be engaged with everyone there, answering questions and sharing their additional thoughts and insights. So we invite you to continue doing that. And then we also invite you to come back to join us for the live session at 2 p.m. EDT this afternoon on the contact tracing, syndromic surveillance, and social media, which is another type of data that would complement our efforts to support pandemic research. So thanks, everyone. And we'll see you guys later. Madhav, do you have anything to add?
No, this has been a wonderful session. Thank you very, very much to all the speakers for excellent presentation, and you all for organizing this. I look forward to the second meeting as well. But please continue the questions. I think that's the goal. These are seeds to the larger discussion that the community should continue to have, I think.
Exactly.
Thanks again.
And I think, Lee, there are questions already, additional questions in the chat as well.
Yeah, so keep the questions coming, and yeah, we really, really look forward to having a great community discussion on these issues.